Hello and welcome to Medaculus. Today's topic is Bell's palsy. Bell's palsy is an acute, unilateral facial nerve weakness or paralysis of rapid onset, less than 72 hours, and unknown cause. The cause of Bell's palsy is unknown. Weakness and paralysis may be due to inflammation and edema of the facial nerve, causing nerve compression and temporary or permanent damage during its passage through the temporal bone. Herpes simplex virus, herpes zoster virus, and autoimmunity may contribute to the development of Bell's palsy, but the exact pathogenesis is controversial and the significance of these factors remains unclear. Complications of Bell's palsy include eye injury, corneal ulceration, and vision loss because of an inability to close the eyelid, ectropion, gustatory hyperlacrimation, facial pain, and paresthesia. Dry mouth because of loss of parasympathetic innervation to the submandibular and sublingual salivary glands. Intolerance to loud noises if the nerve branch to stapedius is affected. Synkinesis, abnormal facial muscle contraction during voluntary movements, for example, facial spasms such as involuntary eye closure during mid-face movement or lip movement when the eyes close, possibly as a result of unusual reinnervation of the facial musculature. Reduced quality of life and psychological complications, diminished facial movement and facial asymmetry can impair interpersonal relationships, cause social distress, social alienation, anxiety, and depression. Prognosis. Most people with Bell's palsy begin to recover, even without treatment, within 2 to 3 weeks. Complete recovery usually occurs within 3 to 4 months. In terms of facial function, the likelihood of significant improvement is associated with the initial severity of facial weakness. Over 90% of people with incomplete paralysis and about 70% of people with complete paralysis recover completely within 6 months, even without intervention. Ba, 2013. If treated with prednisolone within 72 hours of symptom onset, 83% of people fully recover facial motor function after 6 months or more, with most showing improvement from 3 weeks, compared to 72% for people who do not receive treatment within 72 hours. Moderate to severe long-term sequelae are experienced by 16% of people. Other factors affecting prognosis include rate of recovery. Signs of improvement within 2 weeks indicate a more positive long-term prognosis. Age. Younger people are more likely to have better outcomes. Timing of treatment. Initiation of steroids within 72 hours improves prognosis. Pregnancy. The course is typically more severe, and pregnant women are more likely to develop complete facial paralysis with incomplete resolution. Around 6.5% of people experience recurrence of Bell's palsy, with half experiencing recurrence within 5 years. Complete recovery occurs in 66% of people with recurrent Bell's palsy. Diagnosis. A diagnosis of Bell's palsy can be made when no other medical condition is found to be causing facial weakness or paralysis. Symptoms suggestive of Bell's palsy include rapid onset, less than 72 hours, facial muscle weakness or paralysis, almost always unilateral, involving the upper and lower parts of the face. This causes a reduction or complete loss of movement on the affected side, sagging of the eyelid or corner of the mouth, drooping of the eyebrow and corner of the mouth, and loss of the nasolabial fold. Ear and postauricular region pain on the affected side in around half of people with Bell's palsy. Difficulty chewing, dry mouth in 20% of people, and changes in taste in around 35% of people. Poor to incomplete eye closure, dry eye in 30% of people, eye pain, or excessive tearing. Hyperacusis in less than 5% of people, numbness or tingling of the cheek and or mouth. Speech articulation problems, drooling. Atypical features of Bell's palsy require referral for exclusion of an alternative diagnosis and include gradual progression. This is more likely to be associated with a neoplastic or infectious cause of facial palsy. Insidious onset, pain within facial nerve distribution, persistent facial paralysis for over 6 months, or ipsilateral hearing loss, may indicate head or neck cancer. Parotid mass. Predisposing factors for facial palsy, for example, previous stroke, brain tumor, parotid tumor, skin cancers of the head or face, facial/head trauma, or recent infections. Systemic illness or fever. Vestibular abnormalities, for example, dizziness. Diplopia, dysphagia. Hearing abnormalities other than mild to moderate otalgia, hyperacusis, and postauricular pain. For example, ipsilateral deafness, tinnitus, fullness, or discharge. Sparing of brow function, ability to raise the eyebrow on the affected side, may indicate an upper motor neuron lesion, such as stroke. Paralysis of individual branches of the facial nerve or other cranial nerve involvement. Uneven distribution of weakness across facial zones. If this occurs in the acute phase, it is highly suggestive of a neoplasm in the parotid or along the course of the facial nerve. Synkinesis with facial weakness in the acute phase. This is highly suggestive of an alternative diagnosis, such as a neoplastic process. Bilateral signs may be indicative of Lyme disease or sarcoidosis. A recurrent episode. Vesicular skin rashes, indicative of herpes zoster, or ulcerative skin lesions, suggestive of skin cancer. Take a history and ask about onset, progression, and any precipitating factors, for example, head or facial trauma, upper respiratory tract infection. Associated symptoms, for example, malaise, fever, rash, headache, myalgia, arthralgia, cranial neuropathies, such as double vision, hoarseness, or ear symptoms, such as tinnitus, hearing loss, vertigo. Previous episodes of facial palsy, facial, lip, or parotid swelling or uveitis. Current or previous malignancy. Comorbidities and current medication, for example, HIV, immunosuppression, autoimmune disorders, neurotoxic medicines. Current pregnancy or recent delivery. Recent travel, for example, to a Lyme disease endemic area. Recent head trauma. Perform a focused neurological examination and a complete head and neck examination to identify features suggesting an alternative cause of facial palsy. This should include examination of the cranial nerve, ear canal, tympanic membrane. Perform otoscopy and Weber's and Rinez tuning fork tests. Parotid gland. Palpate the parotid gland and visually examine the oropharynx to rule out a deep lobe parotid tumor, which may displace the tonsil medially. Skin of the head, face, cheek, oral cavity, mastoid region. To check for a skin rash, nodules, or vesicles, ulcerative lesions, bruises, or swelling. Eyes and periocular complex. Routine laboratory tests and diagnostic imaging are not required in primary care for new-onset Bell's palsy. A diagnosis of Bell's palsy can be made when no other medical condition is found to be causing facial weakness or paralysis. Apart from uniformly distributed one-sided facial palsy, the physical examination should be unremarkable. Differential diagnosis. Other causes of facial weakness and paralysis include stroke, forehead spared, extremities often affected, brain tumor, possible history of cancer, mental state changes, gradual onset, traumatic injury to the facial nerve, for example, basal skull fracture, or as a consequence of surgery, suggested by history and signs such as bruises or scars. Facial nerve tumor, parotid tumors, may be uneven distribution of weakness across facial zones, with gradual onset of symptoms and palpable mass. Skin cancer, there may be ulcerative skin lesions. Infectious causes, herpes simplex, history of fever and malaise. Lyme disease may cause bilateral symptoms, associated with a history of tick exposure, rash, bullseye lesion in 70%, and arthralgia. Otitis media, otalgia, conductive hearing loss, gradual onset. Mastoiditis, mastoid region tender or swollen. Cholesteatoma, foul-smelling otorrhea, conductive hearing loss, otalgia, fever. Ramsay-Hunt syndrome, pain followed by vesicular rash on the pinna or in the ear canal or pharynx, associated with sensorineural hearing loss. encephalitis/meningitis, headache, neck stiffness, HIV, fever, malaise, CD4 count, syphilis, other neurological and skin symptoms and signs, glandular fever, malaise, few distinguishing characteristics, diabetes, history of, or other symptoms and signs of diabetes, suggestive laboratory test results, multiple sclerosis, intermittent symptoms, and additional neurological symptoms, Guillain-Barré, ascending paralysis, weakness of hands and feet, then trunk, sarcoidosis, symptoms may be bilateral, suggestive laboratory test results, angiotensin-converting enzyme level, arteriovenous malformation. Management of a person with Bell's palsy. For people presenting within 72 hours of the onset of symptoms, consider prescribing prednisolone. There is no consensus regarding the optimum dosing regimen, but options include giving 50 milligrams daily for 10 days or giving 60 milligrams daily for 5 days followed by a daily reduction in dose of 10 milligrams for a total treatment time of 10 days, if a reducing dose is preferred. Antiviral treatments alone are not recommended. Antiviral treatment in combination with a corticosteroid may be of small benefit, but seek specialist advice if this is being considered. For all people with Bell's palsy, provide information and advice about the prognosis and self-care. Advice. Advise the person that Bell's palsy improves at different rates and maximum recovery can take several months. Advise the person about eye care. It is important to keep the affected eye lubricated. Lubricating eye drops should be used frequently during the day and eye ointment used at night. A large range of tear replacement and ocular lubricant products are available on prescription or over the counter. If they are unable to close the eye at bedtime, they should tape it closed using microporous tape. Note: eye patches are contraindicated as the eye may open under the patch, leading to corneal abrasion. Wearing sunglasses when outdoors can help protect the eye. Situations that may cause eye irritation, such as swimming and dusty environments, should be avoided if possible. If they experience eye irritation, pain, itching, or vision changes, they should seek immediate medical advice. If facial weakness or paralysis affects eating, suggest using a straw for liquids and advise eating soft foods. Offer the person written advice or signpost to other sources of information, such as the Facial Palsy UK leaflet Bell's palsy, or the NHS website information on Bell's palsy. Referral. Refer people urgently if clinical features, history, and examination suggest facial nerve palsy may be caused by an upper motor neuron cause, for example lymphoresis, facial paresthesia, other cranial nerve involvement, postural imbalance. Arrange immediate emergency admission for people with suspected stroke. Cancer, for example, gradual onset of symptoms, persistent facial paralysis for more than 6 months, pain in the distribution of the facial nerve, head or neck lesions suggestive of cancer, history of head and neck cancer, hearing loss on the affected side. Refer people using a suspected cancer pathway referral for an appointment within 2 weeks. Trauma, acute systemic or severe local infection. Refer other people to an appropriate facial nerve specialist, for example, a neurologist or ear, nose, and throat specialist, with urgency determined by clinical judgment. If atypical features are present, there is no improvement after 3 weeks of treatment, existing neurologic findings worsen, or if new neurologic findings develop, there is incomplete recovery after 3 months of onset of symptoms. The diagnosis is uncertain. Refer people to an ophthalmologist if ocular symptoms develop at any time, for example, pain, irritation, or itch. Provide advice on eye care measures while awaiting referral. Consider referring adults with Bell's palsy who have developed symptoms of aberrant reinnervation, including gustatory sweating or jaw winking, 5 months or more after the onset of Bell's palsy for neurological assessment and possible treatment. Consider referral for further support or counseling if there are emotional consequences of persistent facial paralysis or paresis. Do not routinely refer adults with an uncomplicated episode of Bell's palsy unilateral lower motor neuron pattern facial weakness affecting all parts of the face and including weakness of eye closure, and no evidence of another medical condition such as middle ear disease.